All right. Hello, everyone. My name is Alex Hughes. I'm Dr. Shaw's nurse practitioner at Austin Urology Institute. And because this is Testicular Cancer Awareness Month, we decided to do a webinar mainly on testicular issues, testicular cancer, and all things about the testicles. So without further ado, I will get started and let me share my screen. Okay, so thank y'all for joining with us today. I really appreciate it. I know it's in the middle of a work day, so I appreciate you getting out here with me. Again, my name is Alex Hughes. I'm the lead nurse practitioner for Dr. Shaw's practice. I've been with Dr. Shaw for about 6 years now. Urology was my first career as a nurse practitioner. I absolutely love the specialty and love the patients that come along with it. My male patients out there, we all have testicles, and things can go wrong with those testicles. So this will be a brief overview of all of the things that we treat and the findings that kind of come with it. So these are the topics that we'll be reviewing. We'll do testicular anatomy overview, the function of it, and then we'll talk about testicular cancer, as that is the awareness this month of April. And then we'll look at the common anatomical conditions like varicocele, hydrocele, cyst, and then some of the more emergency type issues like testicular torsion, epididymitis, and orchitis. So testicular anatomy, the testicles are oval-shaped organs responsible for this sperm and testosterone production, and it's the primary male hormone, which is testosterone is. The the epididymis, which is the epididymis that sits on top of the testicle. It's like the little hat of the testicle. It's a tightly coiled tube situated at the back of the testicle where sperm mature and are stored. So the testicles make the immature sperm cells and they go up to the epididymis where they start to mature, and then they go up the vas deferens, which is the next structure. The vas deferens, the duct that transports mature sperm to the urethra in preparation for ejaculation. And then the spermatic cord, it contains blood vessels, nerves, and the vas deferens. It also houses the cremaster muscle, which regulates the position of the testicles. So the testicles can go up and down, and it's really a temperature regulation. Sperm are very, very sensitive to temperature. So if they get too hot or too cold, the cremaster reflex will either raise or lower the testicles. What do the testicles do? Sperm production. So it's called spermatogenesis. The production of sperm occurs within the seminiferous tubules, essential for male fertility, enabling reproduction. Hormone production. So testosterone. It's the primary male sex hormone produced by the Leydig cells. Influence male physical characteristics such as muscle mass and body hair, sexual development, libido, and mood stability. Temperature regulations, the scrotum acts as a natural thermostat by adjusting the distance of the testicles from the body, ensuring optimal conditions for sperm production. Why this is important, the sperm development requires a temperature slightly lower than the body's core temperature. So it really has to be very specific on where it is in the body. Testicular cancer facts. Okay, so it is the most common cancer in American males between the ages of 15 and 35. This is a young man's disease. I've found it on older gentlemen, but it's extremely rare. The vast majority of my diagnoses come from anywhere from about 18 years old to the low 30s, just like how this is as said. Approximately 1 in 250 males will be diagnosed with testicular cancer in their lifetime, so it's common. Risk factors. So a lot of times my patients will ask me like, what are the risk of developing testicular cancer? Undescended testicles. So that's called cryptorchidism, a significant risk factor. So they never distend. Family history. There is a link to a familiar history of testicular cancer. And a personal history of having had cancer in one testicle obviously promotes or will have you higher risk on having cancer in the other testicle. Survival rate, testicular cancer has one of the highest cure rates of all the cancers. Overall, 95% are cured. So different types of testicular cancers. There are germ cell tumors. These are the seminomas and the non-seminomas. Seminomas grow slowly and are sensitive to radiation therapy. Non-seminomas grow more quickly than seminomas and are less sensitive to radiation. Stromal tumors, rare and typically benign, affect the hormone-producing tissues of the testicles. And secondary testicular cancers represent cancers that have metastasized from other parts of the organs to the testicles, much rarer compared to other primary testicular tumors. As you can see on this picture, this is a normal testicle here. You can obviously see the lesion here sitting in the actual testicular capsule. This is the epididymis and then the spermatic cord. When I do my exams for testicular cancer, I often joke, or I will have even my friends will like text me and be like, "Hey, I think I found something in my testicles. Do I need to be concerned?" When I'm doing my office visits and a patient comes up to me and is, or I come up to the patient and the patient's like, "I think I feel something. I may have felt something," or say, "I felt something last week and I can't find it again." Almost 100% of those are either cysts or scrotal pearls or nothing sinister. When my guy walks in, he's like, "Hey, doc, something's wrong with my testicle." Those are the ones that I worry about. Whenever you do a testicular exam for testicular cancer, typically it's almost like a rigid, hard area. And it's not hard to find. So when my patients are like, "I can't find it," it's almost never cancer. Treatment diagnosis for testicular tumors, diagnostics. So a testicular ultrasound is a gold standard to diagnose a testicular tumor, along with three very important blood labs: beta HCG, LDH, and AFP. These are all tumor markers, and they are elevated and normal within each of the different kinds of seminomas, non-seminomas. But if they're all normal, then would be a good sign. But sometimes, like if it's a gram cell tumor or a more specific tumor, two of the three will be elevated, and then all three will be elevated on the other one. Surgical options, orchiectomy. So just take out the nut. So this is a complete removal of the testicle. And then a standard first step of treatment, lymph node dissection may be necessary depending on the spread of cancer. So a lot of times what we do, especially if we find something that we worry about metastases, we'll do a CT chest, abdomen, and pelvis with IV contrast to look for lymph node involvement. Radiation therapy, this is typically used for seminomas, can be directed to cancer cells remaining after surgery. Chemotherapy, so this is employed when cancer has spread beyond the testicle, effective in treating both seminomas and non-seminomas. And surveillance, regular follow-ups with medical imaging and blood test. So that's it on testicular cancers. Now I'm going to move on to the more common things that we deal with and more common things that my patients typically have. And these are anatomical variants a lot of times. So varicoceles. A varicocele is an enlargement of the veins within the loose bag of skin that holds the testicles, often described as a bag of worms. Prevalence affects approximately 15% of males and commonly found on the left side of the scrotum. So if you're doing your exam and you kind of feel above the testicle and you feel all of this extra material, and it's not on the right side, that's more than likely a varicocele. Um, why we treat a varicocele, there's really two different reasons why we treat this, and there's a third one I'll throw on there. So pain, it can cause discomfort, aching pain in the scrotum, or a feeling of heaviness. So the telltale sign of varicocele pain is a dull pain throughout the day that's relieved with the night of sleep. And if you can think about it, so veins carry oxygen, poor blood back to the heart. So if all of that poor blood is just sitting on top of the testicle and having a really hard time getting back to the heart, that's that feeling of heaviness in the testicle, because literally there is extra blood sitting on top of it. So you do feel heavy. And whenever you go lay down at night, all of the blood in those veins rush to your heart. That's why it's relieved after a night of rest. Um, Infertility. So varicoceles can impair sperm production and function, leading to reduced fertility. They are present in up to about 40% of men that primary infertility and 80% of men with secondary infertility. What to expect? So, like, what to expect? The varicocele is typically palpable and can be described as a mass or dilated veins, often more noticeable when standing and may subside with lying down. Visual symptoms: dilated veins are visible. You can literally look at the scrotal sac and you can see these veins popping out. So, whenever you look in the mirror, if you're looking at yourself and you can see veins just, really protruding, not like typical veins you'll see on the penis or something along those lines. Those are all surface veins. These are very heavy and you can see them almost through the scrotal wall. Treatment options: observe. You can recommend when varicoceles cause no other symptoms and infertility is not a concern. So I have a 70-year-old that comes in and just says, "Hey, I have these extra veins. What should I do about it?" Unless it's causing pain or wanting to have a child, you don't have to take care of it. Surgical repair: there's an open varicocelectomy and a laparoscopic varicocelectomy. Laparoscopic is the less invasive. You have like two incisions along your inguinal canal, and he strips the veins through that hole. Open is opening up the scrotum and taking care of them that way. Embolization, a less invasive procedure where a small coil is placed in the vein to block blood flow. I think that's usually typically done by like a vein specialist. Hydroceles. Okay, hydrocele is a fluid filled sac surrounding the testicle that causes swelling in the scrotum. Hydroceles are common in newborns and usually resolve without treatment. They can also develop in adults due to inflammatory or injuries. Adult hydroceles tend to develop slowly over time. Why we treat these: discomfort. It's almost the same reasons as the varicocelectomy or varicocele veins. Although usually painless, large hydroceles can cause discomfort or a feeling of heaviness in the scrotums. Cosmetic and mobility issues: significant scrotal enlargement can affect the appearance of the and interfere with walking and sitting. Excuse me. Typically, what I see is they get so big, it's very difficult for the patient to get up and move. So, like working out and things like that, that it really starts to hinder that. So, what we can do at the bedside, here's the treatment options: observation. So, this is just do nothing. So, like as long as they are, if they want me to say, hey, that big swollen sac is nothing to be concerned of. I mean, you just may need to get it tapped or surgically corrected. And a lot of times, what they'll do is just observe it. Aspiration involves the removal of fluid with a needle. Just think about popping a pimple. So I put a big needle into the testicle or into the testicular sac, aspirate all the fluid. It's about a coin flip if that's really going to be a permanent fix or not. So I say it's 50-50. The more permanent procedure is a hydrocelectomy. It's a surgical removal of the hydrocele sac to prevent fluid from refilling. And it will basically, so what happens? You got your testicle, you have the sac around it, and then you have the scrotum around that sac. What we do is we cut open the inside sac, the hydrocele sac. We flip it on itself, and so the testicle is now sitting on the outside of that sac, and the leak goes into the scrotum and reabsorbed into the body. About a 95% cure rate on that one. Cyst. This is by far the most common thing that I see in clinic is patients will find a cyst, think it's cancer, and come in for an evaluation. So testicular cysts are benign fluid-filled sacs that can develop in the testicles. Common types include spermatoceles, epididymal cysts, and simple cysts of the testes. Relatively common, often detected incidentally during examination for conditions. So I'm a cysty guy. Like I have moles on my back. I have, moles on my leg. So I always tell my patients when I'm doing these exams and I find the cyst, they're like, should I be concerned? I'm like, no, cysts are rarely an actual problem. Now, what it can actually do is you can see on this picture, there's an epididymal head cyst. So if there's a cyst in the epididymal head, and so the the sperm are trying to go up the vas deferens, you can have some epididymal congestion, which can lead into an epididymitis, which is an infection of the epididymis. So I say like if I did a meta-analysis across the U.S. of every patient that has epididymitis, about 90% of those will have epididymal cyst, but not everyone that has epididymal cyst will have epididymitis. Why treat the cyst: discomfort or pain, often asymptomatic. Larger cysts can cause discomfort or pain or cosmetic concerns. Some men may be concerned about the appearance of psychological impact or having a noticeable cyst. Though rare, cysts can rupture or become infected. Symptoms: what to expect. Cysts are typically round and smooth to be felt as a lump in the scrotum, separate from the testicle. They may be movable and are usually painless. So, like, if it's on the testicle and it doesn't move, then you're worried about cancer. If it's on the testicle and it moves, you start to think about cyst. If it's in the epididymal head, it's not cancer. It's in the epididymal head. It's an epididymal head cyst. Same thing. Treatment options: observation, just do nothing. Aspiration, this is where I stick the needle in it and I suck out all the contents. Again, just like the hydrocele, it's a coin flip if it'll work, 50-50. Surgery removal is considered if the cyst reoccurs after aspiration or it increases inside or causes persistent discomfort. This is typically done through a small incision in the scrotum and is usually an outpatient procedure is what we do. So here's some of the more emergent problems. So if I ever have anyone coming into clinic and they're like, I think I have torsion, I think that blah, 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 they do not have torsion. Torsion is a medical emergency. It is 10 out of 10 pain. And unless it's corrected within about 4 hours, you may have permanent damage. Oh my gosh, I'm so sorry. So, what is testicular torsion? A medical condition where the testes rotate, right? So, you can see on this left, everything is straight. And then on the right, you can see that the testicle has twisted on itself. What this does is it reduces the blood flow, causing sudden, often severe pain and swelling. Symptoms: sudden and severe pain in the scrotum, swelling of the testes, abdominal pain, nausea, vomiting. One testicle repositioned higher than the other. Who is at risk? Most common in adolescents. So these are your 12 to 18-year-olds. The most typical is a high school student that's playing football, gets tackled really hard, and has extreme testicular pain. A lot of times they can have torsion even from just running. They can do that. Diagnosis: physical exam, ultrasound to assess blood flow. Again, these patients are typically not in my clinic. They are at the ER if this is actually a true torsion. Immediate medical evaluation required. Surgical intervention to untwist the spermatic cord must be performed as soon as possible to save the testicle. So if the blood supply is lost for long enough, they will have a dead testicle. Surgery aims to prevent reoccurrence by securing both testicles. So basically what you do is you untwist the testicle and then you tack the testicle to the scrotal wall so that it has an anchor and then it can't twist on itself again. So epididymitis, we've already talked about the epididymis, right? The epididymis is the hat that sits on the testicle. It matures all the sperm cells. So epididymitis, anytime you have itis at the end of a medical term, it's an infection of that cord. Sorry, infection of that organ system. So this is an infection of the epididymi. What is epididymitis? Inflammation of the epididymis, the tube located at the back of the testicle that stores and carries sperm. It can be acute or chronic. The most common causes are STIs, occasionally due to the other infections or non-infectious conditions like urine flowing backward into the epididymis. Symptoms: pain and swelling in the scrotum, redness and warmth to the scrotum, painful urination or urgency, fever, discharge. Diagnosis: physical exam. This is one of those exams. If you have true epididymitis, you're about to hit me upside the head whenever I'm doing your exam. It is that tender. So if I do my whole exam and I mash on the epididymis pretty good and the patient is just sitting there smiling, they don't have epididymitis. Urinalysis and urine culture, ultrasound that we'll send over to ARA, STI screening, treatment, surgical correction of the actual torsed testicle, antibiotic therapy, pain relief measures, and then follow up to ensure resolution and infection, safe sexual practice, and regular STI screening. So we talked about epididymitis. Now we're going to talk about orchitis. Okay, so orc are testicles, itis, infection in the testicles. So you can see here on a healthy testicle, it's nice and smooth. On the right, you have a swollen red testicle. This is orchitis. Inflammation of one of both testicles, often associated with an infection, can occur alone or with epididymitis. And the term for that is epididymo-orchitis. Causes: bacterial infections, epididymitis or urinary tract infections, viral infections, notably mumps, common in unvaccinated individuals. Symptoms: swelling in one or both testicles, pain, tenderness, fevers and chills, and nausea, vomiting. Diagnosis of this: physical exam. It's pretty easy to do an exam to differentiate between a hydrocele and orchitis. Hydrocele is a swollen testicle too, right? But it should have give. It's fluid filled. So if I push on that testicle, you're going to actually have some give from that. If you have true orchitis and I push on your testicle, again, backhand to the head. You're like, get off that testicle. It really, really hurts. So acute palpation pain is elicited from the exam. Blood test to detect viral infections, treatment, antibiotic, pain relievers, supportive care, and then surgical correction. Prevention: vaccination against mumps, prompt treatment of the urinary tract and sexually transmitted infections. And that is our whole webinar on our testicular issues. Um, I hope that y'all actually learned something today and can, do your own self-exams even a little better now. But overall, this is all we had to talk about for testicular cancer. I do know that there are some questions that you can be asking on here. So I will hang around for another 7 minutes or so if y'all have questions. But if not, if y'all need anything or if y'all have any kind of testicular questions, feel free to reach out to me on the portal. But that's it for the webinar today, and I hope you learned something. I will hang out for about 5 minutes. One question I do get asked, the testicle behind, which is hard. All right. I got a question. A hardened mass at the bottom of the testicle behind, which is hardened from time to time and then soften as it disappears. That would be a cyst. Yeah. So a testicular cancer, right? You know, the cancer, it doesn't go away and come back. It's just, it won't ever do that. If the cancer is going to be there, it's going to be there and it's going to be there until you treat it by either taking it out or you put chemo or radiation on it. So if you have something that's going and coming back, then more often than not, it's a cyst. And the cyst, again, they're fluid filled. So sometimes that fluid filled can get really filled and it's hard, or it can be really soft. So if you have something going back and forth, that's probably what it is. One question I do get is how often you're supposed to be doing testicular exams. You should be doing a full GU exam on yourself once a month. So basically, what you do is if this is your testicle, like if you're in the shower, get your fingers on top of the testicle and run them down the side. Okay. And then you start from here and you rotate the testicle, then rub your fingers up the side again. Rotate the testicle and then do that again. Whenever you feel the epididymis, which is that hat, run your fingers along your epididymi. Find your vas deferens. Even run your fingers along the vas deferens. What you're looking for are lumps or bumps that are not part of your normal anatomy. Now, again, it's very easy for me to tell that, but I don't have to tell y'all what I do for a living, and I feel testicles all the time. That's part of my workup. So I can really differentiate. So if you have something that you want me to assess, make an appointment. What we will end up doing is I'll do an exam, but I offer all of my patients an ultrasound if they want to just make sure. And the beauty of an ultrasound is it's no radiation exposure. It's usually pretty affordable, and it's the gold standard for any testicular issues. Right testicle seems more concise and substantial, while the left more heterogeneous. I'm not sure I follow that question. Right testicle seems more concise. Are you just saying it's smaller? Because that's extremely common. Left testicle is naturally supposed to be about 3 to 5% bigger than the right testicle. Left more heterogeneous. I'm not sure what you mean by that, but if this is something that you want me to assess, just come in. We have offices all over Georgetown. We have Leander, and then we have our main office off the Domain. If it's something softer, as it is softer, the left one. So the soft. Oh, so it's just softer. That's fine. Yeah, there's no when it comes to mass of the testicle, and I'm not talking about a mass, I just mean the mass of the testicle. Everyone's are different. I will assess everyone's testicles, and every testicle I assess does not feel exactly like the one previous. So sometimes there's give, sometimes it's more hard. As long as it's hard throughout the testicle or soft throughout the testicle, it's okay. All right, guys, it is 3:30. That was it for our testicular cancer slash testicular anatomy overview. If you felt like this webinar was good and you learned something from it, feel free to reach out to me on your portal, or just message me and say, hey, we really enjoyed it. We're trying to figure out if we want to keep these things going, and we're trying to figure out a great format for our practice. So please send in any kind of recommendations or anything that y'all learned or liked about the webinar. And I will do this again in another month. Thank y'all. Bye.